Good morning. I thank Professor Shihab, Professor Akbar, and Professor Fawaz for inviting me. Always Dr. Akbar and Shihab asked me for some unusual cases of acute coronary syndrome intervention, and so I picked some snapshots from our cases. This is our ischemia club, Egyptian Board of Intervention Cardiology. Every other Wednesday we have a webinar. So this is a typical case of unstable angina. She is a female. She has a proximal LAD lesion. She's 40 years old. It's a very classic case. However, remember that her angio 6 months ago was normal and she had the same symptoms. And so always the patient is right. You should not ignore the symptoms. This is another patient. He's 42 and he had the stress test 3 days earlier that was negative, but he had acute infarction. The technical part that the LAD is compared to the left main is huge, and so you have to technically land the stent at the edge of this ectatic area, otherwise it will be floating in the LAD and in the left main. So always take much more consideration for the symptoms and don't rely on only one test. This is unstable angina, and all the arteries are rising from the right coronary cusp, and so this is a guiding case. There is a lesion in the LAD and lesion in the ostium of the CX, and so it's a case of guiding and wiring. You have to go a little bit deep in the LAD, in the left coronary artery, and then to wire carefully with very weak support. But finally, we were able to put a stent in the LAD and in the ostium of the CX. Of course, I may require imaging, but having this case with little support, it's difficult. So we did the 2 lesions peacefully. So acute coronary syndrome may present those cases with stent restenosis. It may present with angina, and they may present with acute infarction like these patients. And so take into consideration these multiple stents. This patient is liable for many complications. He had actually no reflow after we put a stent in the distal part, and we had to put DCB in the proximal parts. So don't ask me why this patient did not complain before. Maybe he had some atypical pains or not, or his chest pain was not taken into consideration, but he reached us with acute coronary syndrome, and as you see, it extends even from the ostium of the LAD and the distal left main. Of course, imaging, DCB, and good anticoagulation, antiplatelets are the cornerstones in management of such patient, and in this case, of course, we wired the CX when we put the stent from the left main to the proximal LAD. So this is another patient, he's 65, acute infarction, anterior. The difficulty of it is pinpoint obstruction in the ostium of the LAD, and the left main and the LAD are huge, and so and the wiring is difficult. Then you need to do double wiring, double care for the wire to reach for the this lesion. I didn't consider surgery because he's acute infarction and because of his age. So wiring was difficult, but we did it. And then we started by opening both the ostium of the LAD. It did not yield well until we had a bigger balloon. It's 4 by 15, and then we started with the proximal LAD lesion that was thrombotic, but you cannot do only this patient, this lesion, and wait for the ostium of the LAD to occlude. So the difficulty in this patient was the wiring, the ostium, and the size. Before you do this, you always look for a big size stent, and fortunately we found a stent that was 4.5 by 15, and we found a balloon that is 5 that can go up to 6. This is the LAD proximal lesion. And then this is a stent We try to avoid the ectatic area again in the LAD. We put it mainly in the left main and partly in the ostium of the LAD just before the ectasia. The same notion to avoid floating in the ectatic area. This is 4.5, and then we used a bigger balloon, and so it opened. There was a little pinch of the CX that improved after nitrates, and the patient did well after that, and he was fine. This is a patient, he is Saudian, he is visiting Egypt, he is 70, he had acute chest pain, STEMI, cardiogenic shock. They did this angio for him at certain district. There is a thrombus in the CX ostium, and there is total occlusion of the LAD. They discussed with surgeons, and of course he was declined. Ejection fraction was low, and the blood pressure was almost 80. And so they sent this patient to us. By that time, his pressure was only 60 to 70. And so, they started him on 2B3 antagonist until he arrived to us. By the time he came, the thrombus was a little bit less in the CX. Started the intervention by the CX, and then we ballooned the lesion, the distal left main, just to disengage. After opening the distal left main, we started to work more safely. Blood pressure a little bit increased. Then we just put a stent in LAD, and we did a simple tap for him, and he was revived. This was almost like 3 or 4 o'clock in the morning. So most of these patients in our country, when they have such case, they ask for surgery. Speaking of the previous lectures, and then surgeons may say it's declined, and then the patient will stay in the ICU, and then he will die. So always continue the journey. You should offer him something, and that's what we did. Afterwards, it was just a tap, and all the regions were opened, and he's still alive now. Ejection fraction improved during the follow-up. It reached 40%, and his condition stabilized. This is the final kissing. Of course, pot and then rewiring, and then final kissing, and this is the final picture. This is the picture. So this is another patient. He had a total left main occlusion. Again, we can say this is a surgical case, but in these cases, of course, with such poor contractility and low blood pressure, he may need ECMO or Impella, but this was in also after midnight. So we try to pass wires in both arteries, and they try to open whatever you can. So after opening after wiring both LAD and CX, we started by the CX. Because the LD was still occluded, I can't put a stent while it is still occluded. We need to do something before to revive the patient, and then we can improve. So this is a CX lesion. He was going to arrest, but he was revived. Blood pressure was 50 or 40, and of course, again, if I have ECMO or Impella during night for such patient, but if not, then you try to do revascularization as much as possible. The end of the story is we open the CX, and then we improve the LAD, and then we stented. We do a keyload technique from the LAD to the left main, and the conditions were stabilized, and the patient survived. Sometimes unstable angina or non-STEMI, and the wiring is difficult like this patient. You can hardly see a staining, and then there is a gap. And those patients are liable for dissection, and you should be careful when you need to do several curves. You need a curve in the initial and then a secondary curve. And this case it was done with a Fielder XTA. the stain was just the mark for us where to go, where to find, and this is a non-STEMI case. The right coronary is, fortunately, was good. So, although the patient was acute, but you have to be careful with wiring. So some cases, the difficulty is just to reach the artery exactly as if you are driving your car. So, 2 bends, then we finally reached the LAD, and the rest of the case was easy, just to open by balloon and then stent. So this is the last case. Patients, she's 65, mitral stenosis, prepared for balloon mitral valvuloplasty, but she has acute attacks of pulmonary edema associated with chest discomfort. And so always in mitral cases, remember to visualize the coronaries. Like in this case, we found a right coronary. This may explain the ECG changes, the chest pain, the pulmonary edema. It is not only the mitral stenosis. And so we did the mitral case as usual. We just balloon the mitral. Mitral is not as common as in old days, but still we have in the heart institute many cases. This is septal puncture. Then the INWI wire. Can I have only 20 seconds?
1 minute, please. Slides.
Yeah. Okay. So the rest of the case is we did the mitral, and then we next morning we did the right coronary because anticoagulation and mitral valvuloplasty, you cannot guarantee that there is no retroperitoneal hematoma or something, and so we did the case. So those are part of my team, and I invite you to Egyptian Society of Cardiology working group intervention in December and Combat MI in March. Thank you very much.
Thank you.